Right. Hi, everybody. Welcome to today's webinar. I don't know what time it is that you are joining us from, but it is evening right here in Nairobi, Kenya. I know it is late, it is at night in India, and it is early afternoon, maybe in the UK. So thank you so much for spending your afternoon or evening with us. We are going to learn about advocacy and policy making and what that means when it comes to mental health and the role that community has. And so we are going to have an amazing time. So thank you so much for joining us. My name is Brian, and I will be facilitating today's session. I am based in Nairobi, Kenya, and I am joined by two wonderful speakers. We have Jeet, who is in India. He's the team leader for Burans, and in a bit he's going to be introducing himself and just sharing his wealth of experience and stories in this field. And then we'll have Winnie, who is based in Kenya. She'll just come in and also just give her insights, and then we will get into a time of questions. But as they speak and you maybe have a question in mind, just feel free to pop that in the chat section, and then we shall get to it afterwards. For those of you who have not interacted with Aruka before, we are a charity and we specialize, or we just work to improve the health and well-being of communities together. And so we value collaboration. That is at the heart of what we do. And we love making sure that the change comes from within. And so if you would like to learn more about that, you can visit our website, maybe after the session, arukanetwork.org. But before that, let's just get into the session today. And I would like to introduce Mr. Jeet, who is joining us from India today. So Jeet, the floor is yours. Feel free to just let us know a bit about yourself and then maybe share a few things.
Hi everyone. Good evening from India because it's late evening here. So my name is Jeet Bahadur and I'm working for Burans over the last 10 years. And currently I am leading a 40 people team members up in the mountain, which is a rural area. And I'm basically a mental health practitioner. And in my role is in Burans is to training the team and field support, networking, and advocacy part. So this is my main role in Burans. And so now, should I start my presentation, Brian?
Yes, feel free to start. Thank you.
Okay, so basically, I'm going to speak about advocacy and how we are doing advocacy in Burans, and same time how we are building community also to do the advocacy, because we feel it's very important things when it comes to community mental health work or any community development help, because advocacy is something that unless we raise our voice, government is not going to provide us their services or anything that we really required. So basically I will just tell brief about the Burans, what sort of work we do, and then I'll jump into the advocacy. Yeah, next slide. So basically, Burans work with disadvantaged communities in Uttarakhand. So, and we promote mental health in resilience by building on their strength and resources, whatever resources they have in the community. Based on that, we try to build up their capacity and resilience. And we are working in two districts. One is up in the mountain, which is called Uttarkasi, and in Uttarkasi there are two blocks, Mori and Purola and Nogao block, which is a rural part of hill area, and then another area is in urban area, which is in Dehradun. So we have a two team, and we currently we are serving more than 200 communities, And our approach is to building relationship with community, with government, and with other stakeholders, and then empowerment of the community. And our approach is right based approach. Next slide. Yeah. So when it comes to a building relationship, so specifically when it comes to a mental health work, so we are working with DMHP. DMHP means District Mental Health Program and Health Department, which is responsible for implementing mental services to the community. So we felt it is very important to work with the government. So we engaged with the DMHP team, and we went to them. We introduced ourselves that this is a Burans. Burans is going to work in the community, and this sort of work we are going to work in the community, and how we can support DMHP, which DMHP can also provide quality service at community level. So this kind of like approach we took, and we shared our vision and mission and our activities and every objective with the DMHP team. And then we referred the people with psychosocial disability to the DMHP, where these people can get treatment, and same time DMHP team can only treat them, but at the community level, our team can follow up whether they are taking regular medicines, if they are having any side effect or anything. So we try to explain them, and we take the patient to the DMHP or to the doctor to explaining them whatever problem they are having. And then on the occasion of World Mental Health Day, we invite the MHP team, and same time we invited people from the community, especially lived experience people. And that was the time where these people have opportunity to share their problems, you know, the challenges or gaps in terms of medicines. And same time the DMHP team also come to know the problems of the community. So and then we continue to update the DMHP team through a newsletter, uh, face-to-face meeting, social media, or media. And then we also supported DMHP team whenever they requested us, whenever they needed our help. So we always there to help them out, so that these people also can come to know about our work, our objective, and by supporting them, we try to gain their trust. So these were the strategy to engage with the DMHP team, and same time understanding their work and their policies and their program, so that when we know the program of the DMHP, so that we can also go to the community and tell them these are the programs, and we also aware the community about the DMHP program. Next slide, please. And then strengthening mental health. So we go to the community, we do the awareness, and then we identify the people. If people have any problem related to mental illness, we refer them to the uh, DMHP team, so that they can be identified. And then if they feel that this person have some mental illness problem, then they give the treatment. So you see in the picture, so there is our team who brought the case, which is suffering from severe mental disorder. And when DMHP doctor come to know that with the support of Buran's team, they are getting patient to the hospital, and they are now getting lot of patient with the support of Buran. So they really appreciated our work, and they started trusting us. And then that's how we were building our relationship with the DMHP. And our side, if any patient needs psychosocial support, so our team used to provide the psychosocial support to the PPSD, the people with psychosocial disability, and the family member, explaining them what sort of problem he's going through, what is the problem he's having, and what kind of support he needs from the community, from the family, from the caregiver. So all skills that required for good caregiving, our team used to go to the community and speak with the family member, and the community member also, so that the person who's going through the problem, he can get the support from all the or from all side, from the community, from the hospital side, and from the family side also. And then we also created database, because we felt that it is very important to create a data, so that whenever we are going to say the things, before the medical team or before the health authorities, so we should have some kind of data which explaining the challenges or gaps. So by telling the data, you justify your problems, and then people, especially the government, they start believing us, because we are not just going and telling them the things, but we are we are verifying those challenges or gaps through our data. Next slide. So when it comes to advocacy, it is very important that we realize that the capacity building of the community is very important, because basically uh, we have been doing the advocacy on behalf of community, but we thought it is not enough, because the authority or the health department doesn't give that much attention to our problems. Whenever we say that there are the gaps, these are the challenges, so they really don't give that attention. So then we thought it is very important to build up the capacity of the community. So we formed the EBE group. EB means expert by experience or lived experience people group. And then people, disabled people organization also, so that we train them on their right, what is the right, what is the mental health act, and what is the right in the mental health act, and what government supposed to deliver as per the mental health act. And then we also train them on right, RTI, which is right to information, and CM, chief minister portal. The portal where these are the some platform where you can file your, like, you can lodge your application, whatever problem you are having, or if you want to know any government uh, services, or you need to know any information, just you need to put the application, just mentioning all that under RTI act, I want to know about the DMHP program, and what are the program, or what are the services being provided by the DMHP, so that people get the exact and correct information. So these kind of capacity building we did. Apart from that, we also train them on what kind of social services being provided by the social department. And these are the some strategies that we have really took to do the advocacy. So we made the plan. So, like, we involve the community stakeholder, like expert experienced people, DPO, disabled people, organization people, and then Buran side also. So then we decided amongst us who will take what responsibility, and how they are going to raise this issue before the department, and where. So that's how we develop our strategies. And based on that strategies, then my main responsibility was to speak with the higher authority and to media also. So when I sensitized the media, then media really helped us to highlight the mental health issues. So if you see on the right side, there is a cutting of the newspaper. This says none of the district has got the medicine for psychotic patient. So when these kind of report the policymaker came to know, then immediately they called all the CMO, Chief Medical Officer, and they gave them the instruction, immediately you have to arrange all the psychotic medicine for the people with psychosocial disability people, so that they should not need to travel very far to get the treatment. Next slide. Yeah, so then the impact of advocacy, what happened when we raise the voices in different platform, like people with psychosocial disability people also, we ask them to file the complaint on CM portal. and then file RTI. Then I was also doing the advocacy, and the community level, the key leader were also doing the advocacy. They were demanding for the doctors and for the treatment. When we started our work in Purola and Nagaon blocks, there were no psychiatric doctor or the medicine were available. So when we identified the cases, so we identified 84 people with psychosocial disability. They and most of them were suffering from severe mental disorder. We made the list, and then we went to the CMO in Uttarkasi, and then we explained them these are the patients that we have identified, but there are no any facilities, no psychiatrist, no medicine, so where to go? And they are living in the community without any treatments, and the family and the community also suffering. So then immediately they took notice of those things. Then they deployed one psychiatric doctor at the community health center, where patient got the treatment and they were seen by the doctor. And then we became the part of state mental health authority also. The authority is responsible for making policies for mental health, and same time to monitor all the mental health related organization, whether they are delivering quality services or not. So now we, the Burans, is part of state mental authority, and we also participated in drafting policy for de-addiction center, and we demanded that these all de-addiction centers should have psychiatrists, psychologists, so that these people have proper quality services at de-addiction center. And then we collaborated with DMHP, because when they saw our effort, our work, and then they trusted us very lot, and then they looked us as a supportive partner for them, those are working in the field. So that in a way we are supporting to the DMHP to deliver their quality services at community level. So there were very good understanding, and they also offer us to work with collaboration. So that's how we collaborated, and right now we are working with the collaboration with DMHP in both the district. Next slide. And then this is the story. There are a lot of stories, but this is especially I want to explain. So initially the community, they are not very confident, they are not very aware about the advocacy, they don't know how to talk to the official, so they are not very confident, and they were very much relying on us. They said, since you people are here and you are doing wonderful job, so why there is need for us to learn all those skill and to meet these people? So we are very much counting on you people. So we said no, because one day we have to leave this area. Whatever work we are doing, the same work you can also do it. You don't need to have any education or any training session, but just some knowledge or some skill which we will transfer to you. So we did head-on kind of training with them, and we formed the group, EB group, expert by experience group, and disabled people organization group, and formally we registered them. Then we helped them to draft a letter, and then we assist them to go to the CMO, and we ask them to present your letter to him and explain your problem. And just we were just behind them, and when they were explaining about the all this non availability of the medicines or doctors, then immediately this CMO took notice of their uh, problems, and he directed to the DMSP team to conduct a camp in both the community center with medicine. So when these people came to know that with their effort, with their advocacy, that now the service is immediately available for them. So it was very something very exciting for them, and they become very confident, and now they want to put more and more RTI, and they are asking government to deliver the services at community level. And that's how we are just hands-on training and support to the EBE group and to the DPO group. Next slide. But same time there were some challenges also we faced, as we this is almost 5 years we are working in Uttarkasi areas. So the challenges, when we deliver the services, so community become very dependent on us. So so they very much counted on us. So it was, it took a lot of time to make them understand, to engage with our activities or advocacy. So this kind of challenges we face with them. Then the low awareness and less engagement of these people. They don't know, the community people don't know what is their right, what are the platform where they can file the complain or access the information, what kind of services are available for them. So no idea at all. Then the advocacy is always time consuming process. You need, you need lot of knowledge about the policies, about the program, and based on that only you able to find the gaps, and then you record all those gaps, and then you have to, go to the proper place and explaining them and verifying with the evidence. And it is very long process, and you need lot of patience, and you have to spend lot of time, traveling, sitting, speaking. So this is very time consuming process. Another misconceptions about the funding. So what they feel, NGOs always get the fund, so this is your job to do the work. So why you are counting us? You do your work, we will do our work. So that is a conception about the funding. But here we always gain their trust that we are here to support you and to help you to deliver your quality services at community level. Then lack of information also. When we were asking about the program, so they were not really providing us very correct information about the health program, what kind of health they have, facilities they have. So always hesitate to give the information to us. They said, why he's asking, he may make the misuse of all information, so my job will be in the problem. So there was like a less trust. So these kind of challenges we faced in terms of doing the advocacy. Next slide, please. Yeah, so our learning. So what we realized right from the beginning involved the community or the group in our program. So by doing the core designing, so with the community and the relevant groups, and explain them, these are the things how we are going to do. So right from the beginning involve them in the program. And then hands-on training is very important, because uh, they are not, their education or their qualification or their understanding is not that level that we can give them the theoretical session, but hands-on kind of training and support, and assisting them for doing the advocacy, taking them to the hospital or offices and showing them the way. So everything, that kind of training is very helpful for such people. And then involving their right from the beginning, as I explained early on. And then networking is very important. So we did lot of networking with local NGOs, key leaders, and then the local team and the government, and it really helped. Then we also sensitize them on mental health issues, so that we get support of the community, political leader, government, or other active NGO member. So these were our learning. So thank you. If anybody has any questions, so I'm happy to answer.
Thank you so much, Jeet. Uh, Thank you for sharing about Burans and the wonderful work that you've been doing. I think maybe what I am learning at this point is the value of collaboration and working together. And yes, we do have a part to play in raising our voice, but when we do it together, then it is more effective. So thank you for sharing that. And I think I've also valued your um, you talking about working with the government and earning their trust by supporting their work and the impact that your work has had in Uttarakhand, India. So thank you so much for sharing, Jeet. And if anyone has any questions, please use the chat section, and then we can come back to the questions towards the end. But at this point, I wanted to also introduce Winnie, who is joining us from Kenya. Winnie also is an advocacy officer, and she has experience in advocating for mental health as well. And I'm just going to, ask her to share with us, her experiences and her insights as well. So welcome, Winnie.
Thank you so much, Brian, and thank you so much, colleagues, for joining from all over the world so that we can have this discussion. Kindly, Brian, confirm if you're able to hear me.
Yes, you can share the screen.
Thank you so much. I also want to ask you to kindly allow me to share my screen. And while you are doing that, want to introduce myself, and then I'll be able to share with colleagues. So my name is Winnie Okoth. I work for Tinada Youth Action Africa. Tinada is a youth-led, but also a youth-serving NGO based in Kenya. We work in all counties in Kenya on issues mental health. We work on mental health service delivery, but we also work on advocacy. Majorly this discussion, I want to share with us the work we have been doing on mental health advocacy. But before that, I want us to understand the gaps that exist in Kenya on mental health. So Kenya, just like any developing country, or generally globally, the world is experiencing the burden of mental health because of economic challenges and just difficult times that have worsened over time, and Kenya is not left behind. And because of that, there has been increased need for mental health services. But as even the need for mental health rises, the services for mental health has not increased, especially in Kenya. And besides policy, there are several gaps on service delivery. We don't have adequate personnel, psychiatric nurses, psychiatric doctors, or even just workforce for mental health. So one of the gaps, especially on policy that we have in Kenya, is limited government funding. You'll find that mental health receives less than 1% of the total government budget, especially on health. The other one is that mental health is not integrated into primary care. You find that in Kenya we have the health insurance systems. We have it is called SHA, social health insurance, but they do not cover mental health. Again, we also have inadequate policies at the county because Kenya has different levels of governance. We have the national level, and we also have the county level, which is subnational level. So we do not have adequate policies at the subnational levels. Another one, we have some counties have policies, but then the policies are not being implemented majorly due to limited funding and also lack of personnel. And just lastly, workforce shortages that I have mentioned. These are just some of the gaps that exist in Kenya in regards to mental health, but the list is not exhaustive. I want us to also understand the work that Tinada has been doing on mental health. In Tinada, just like I mentioned at the beginning, we are not only doing advocacy, but we are doing mental health service delivery. We work with psychologists currently. We have over 20 psychologists who are able to offer psychosocial support physically, but they also offer through teleconferencing. And we work closely with the government because the personnel, the government do not have enough workforce, and we know that service delivery is the role of the government. So we work closely with the government. They refer to us, but also we refer to them as on need basis. We also work in communities, we work in schools, we work in prisons just to ensure that we are able to complement the services they are currently doing. But just like I mentioned, I want to focus specifically on advocacy and some of the strategies that we have been able to use in Tinada to enhance mental health advocacy. So one of them is holding stakeholder discussions that influence mental health dialogues. We do this at the grassroots level, but we also have the technical working groups at the county and also at the sub-county level and even at the lowest level, that is at the ward level. We hold these discussions, we bring in community gatekeepers, we bring in experts, and just the common citizens to discuss issues on mental health because there's still a lot of stigma around mental health. Tinada has also used the strategy of supporting mental health structures, just like I mentioned. We have supported, especially in Kisumu, we have supported the county government to put in place sub-county mental health structures. And the sub-county mental health structures consist of the county government. We also have the CSOs, we have faith-based organizations, we have experts offering mental health, other institutions that are also working on mental health. It is a platform that is bringing all stakeholders involved on mental health, including organizations of persons with disability. We also have youth and women represented in the structures. Again, we have also been engaging political targets, specifically the county assembly, and this is specifically on policy enactment. We also do policy dissemination, and this comes after Tinada supported Kisumu County government to establish Kisumu County Mental Health Action Plan 2024 to 2029. This action plan was launched last year, that is 2024, but it is helping in putting in place the structures, the budgets, and the workforce for mental health in Kisumu County. Another strategy that Tinada has been using is training of mental health champions. We have so far trained over 200 mental health champions that have spread all over the county. The champions are not only doing mental health advocacy in community forums like Jeet Bahadur's radio talk shows, and generally any platform that engages the public. But they have also been our contact and contact persons, and also been helping a lot in doing referrals because the champions exist within their communities and the community can easily access them. So when they identify a case within their community that needs support, then they refer. Another one is on supporting development of policies. So far, Tinada has supported development of 3 key policies in Kisumu. One of them that I've mentioned already is the Kisumu County Mental Health Action Plan. And currently we are supporting the development of Kisumu County Workplace and Wellness Policy. And we are foreseeing that at the end of this year, the policy shall have gone through public participation, through validation, and finally launching before December. We are also, as the workplace policy is going on, we are also starting the mental health policy. Another one is supporting awareness campaigns, and we have supported awareness campaigns through different platforms, specifically so that we are able to target different audiences. We use the local radio stations. We have been using community forums like the Jeet Bahadur. We have been using international observance days like World Mental Health Days. We have generally been creating awareness. Even we have theater team because there are audiences that relate better with theater. So we have also been reaching them through theater performances. And just mentioned a few strategies that we've been using, and I also want to share some of the achievements that we have made so far. So one of them is that Kisumu County has started forming mental health structures. When we started this, we started in 2023, and by that time, for you to access mental health services in Kisumu County, you had to go to Kisumu County Referral Hospital or Jaramogi Oginga Odinga Teaching and Referral Hospital. Those are the only health facilities that were offering mental health services. But because of the advocacy work that we have supported and also joined with other CSOs, I cannot attribute this achievement to Tinada only, but also the collective voices of CSOs in Kisumu County. The county has now established mental health structures in each sub-county of Kisumu, and I mentioned the composition of the mental health structures. So the mental health structures simply support in advocacy, ensuring that during public participations, the county government puts in place budgets towards mental health, but also it helps in reducing stigma and creating demand for mental health. I'm also proud to say that Kisumu County has also appointed 7 mental health coordinators. So Kisumu County has 7 sub-counties, and through advocacy work that Tinada has been strongly supporting, the county now appointed 7 mental health coordinators. Mental health coordinators generally coordinate the mental health structures. And the county also appointed a mental health facility for all persons. Just like I mentioned, Kisumu initially only had 2 health facilities giving mental health services. But through the advocacy work that has been done by Tinada and other CSOs, the county government now appointed health facility for all persons in 7 additional health facilities spread across the sub-county. And the facility for all persons ensures that there is mental health referrals. They also support in data collections and ensures that cases of mental health are reported, because in most of our facilities, we do not have trained personnel that can give even psychosocial first aid or can even do diagnosis for mental health. So the facility for all persons comes in to support with this. I would also want to say that Tinada has consolidated voices of Kisumu County CSOs, and now they are able to influence policy. And this can be demonstrated by the Kisumu County Mental Health Action Plan that has been put in place. It was launched last year in June, and now we are in the process of developing the workplace and wellness policy and also the mental health, Kisumu County mental health policy. And through this, Tinada has also brought together CSOs through a mental health alliance. Besides the technical working groups, the CSOs in Kisumu have a mental health alliance that they jointly push for policies on mental health. I would also want to, because they have mentioned the issue of the mental health action plan, I would also want to mention deployment of psychiatric nurses to peripheral sub-counties, because you find that most of the services were available to only specified facilities and had to reach populations or communities residing in peripheral sub-counties were not able to access mental health services. So if they were to access mental health services, it meant that they incurred a lot of costs and also had to travel long distances to access these services. And currently, with the economic burden that the world has been grappling with and also priorities, you find that this left vulnerable populations from accessing mental health services. And through advocacy efforts, the county government has now deployed 2 psychiatric nurses to 2 additional sub-counties, and now the residents of that sub-county do not have to travel long distances to access mental health services. I also want to mention that we have also strongly brought in organizations of persons with disability. This is specifically on inclusive mental health advocacy, because mental health is already a new mean, it's generally relatively still new to the world, but now inclusive mental health uh, advocacy and also inclusive mental health service delivery is even now far much new. That is why we are working with organizations of persons with disability to ensure that they push forward their needs, and even as policies are being put in place, they are keen to ensure that their needs and demands are not just then because of sympathy, but from a right-based approach. I might not be able to say all the achievements that we have been able to make because of time, but I also want to share some of the challenges that we've experienced while doing advocacy. One of them is from political transitions. You find that in a span of 2 years, we have different county director for health, we have different chief officer for health, and you already started in conversations on advocacy. But when we transition, when we have new leaders in place, it means the efforts that were already put in progress and rolling now have to be started over again, because you need to start to have a buy-in and now just bring them on board for policy advocacy. Another challenge that we've experienced is underfunding, and this is not only in Kisumu County. Generally, mental health is underfunded, and in national and even in county budgets, this leads to severe shortage of resources. In Kisumu County, for example, does not have a pediatric psychiatrist, so it means there is no for service for mental health service delivery for children, we do not have a pediatric psychiatrist. So that is a gap. And even we only have 2 psychiatric doctors in the entire county. And this should closely relate to the budget and even medications for mental health. Mental health medications are not cheap, and county has not even budgeted for them. So you find that there are a lot of gaps. There are a lot of gaps on policies, but also on service delivery. And another challenge is on that mental health programs are left for donor funding. You find that the government do not have budgets for mental health. And now with the stop work orders, for instance, in Kisumu County, the mental health diagnosis was left to the DCC department, but now with the stop work aid and the funding cuts, it means there is no health worker that is going to support in identification of cases of mental health within the health facilities at the grassroots level. So this is also a challenge. And last but not least is the lack of trained personnel that I also mentioned. So Brian, I want to end at that point, and I want to thank you for giving me this opportunity to share the work that Tinada has been able to do on mental health, and generally join other colleagues across the world who are keen on mental health advocacy. Thank you, and back to you.
Thank you, Winnie. I think you may stop sharing your screen so that we can see each other.
Okay. Can you just, oh,
All right, thank you so much. Thank you, Winnie, for sharing. It's been very insightful to listen to the work that you're doing in Western Kenya. I think maybe the story that sticks out is, because of you coming together to advocate for mental health, the stigma has reduced, and with the government not having a budget to psychiatric nurses being employed and centers coming up, just goes on to show that advocacy works when we come together. So thank you so much, Winnie, for sharing. I believe Mona has shared a message with you in the chat section about potential partnerships. So you may have a look at that and maybe an email that has been sent your way. I have maybe a couple of questions here in the next maybe 10 minutes before we leave. So these ones are maybe directed to both Winnie and Jeet. And I think maybe the first question is that, you know, Jeet, from your story you shared about ideally people over relying on you because you've been doing most of the advocacy. And I think also just with the stigma that's in communities. So I think the question is, what would you advise somebody who doesn't know where to start, so that maybe they can not over rely on you in case they need to do it themselves and maybe are afraid to. So Jit, you can maybe have a go, and then Winnie can also share about that.
Yeah, it is very important what we realize. We have been doing most of the time all the advocacy, but later on we realize that this is not a sustainable model. So what we have learned that right from the beginning, just engaged in your all program process. So better to conduct the core design activities with them so that they feel included, or and you can develop the sense of belongingness to the project. Otherwise community feels that this is like your responsibility to do all these work, why you are asking us. But when we do the co-designing with the community, and then we give them the sense of belongingness in the project, then it is very useful. So this is what later on we try to form the EB group, expert by experience,
Mhm.
disabled people organization, and key leaders. We involve them, and then we discuss, how to do the advocacy. Okay, this is the program is available, but this is not implementing on the grassroots level. And to access these services, you have to travel so far, and it is everybody is suffering. But when you raise the voice, then government will listen it. This is your right. So same time you have to build up their knowledge, what is the program, what is the scheme, and then train them on the advocacy skills. And what we did in our scenario, because the community people, they learn very quickly when we do hands-on training. So and then assist them, taking them, and then also connect them with the network also, taking them to the CMO office, health department offices, DMSP team, so that these people also know what is going on, and same time they also learn, so that they can take more steps. So that's why we trained the group, and then we assist them how to write the application, and then we took them, and then before that we trained him. Then he explained his all the problem before the chief medical officer. So then
Mm,
he thought, now it is not the NGO, but this is the community representation, and community is telling the process. So immediately he took the notice of that, and he called the DMSP team. He said, "Why, how we can conduct the camp?" Then after 3 months, they deployed the psychiatrist and the medicine.
So yeah, I think uh, you know cultivating that sense of belonging is important from the word go, so that they also feel like they are part of it. That's very helpful, Jit. Thank you for sharing that.
And then it will help you to transition your responsibility to the community.
Hmm. Yeah,
Otherwise, community says, no, no, we will not allow you to go move out of this place because you are doing wonderful job. So, but
yeah.
that is not our job. Our job is here to build the capacity or the skill of the community so that they can lead their way there as they want.
Hmm. And then that goes on to become individual advocacy as well, because they now are equipped with everything that they need.
Right. So you will not believe, there are 40 people teams, only 3 people from the Dehradun. The rest of the team we have chosen or we have selected from the community with the consent of key leaders, ASHA workers, and other stakeholders.
Mhm.
And these people are going to stay in the community. So we are
Yeah.
basically building up their skills.
Mhm. Yeah, very helpful, Jeet. Thank you so much for sharing that. Ted says in the chat that it's impressive how both the programs are linking with the government, and the role of the government is really important. And it's important to make sure that the government is also taking a responsibility and taking charge,
And
because it is.
yes. And one more thing, and you will not believe, it is the government who force us to become a part of state mental health authority department. He said, you people are doing the work at grassroots level, you know better, so you will be a right people to advise us to draft a very effective or quality policies for the people. And what we have done, we have forced one community member to become a member of the SMHA, State Mental Health Authority, which is responsible to implement mental health policies, to monitor in across the state, so that it's not like bureaucratic people are drafting the policy. The real voices are heard from the community as well. So this is our great achievement.
Yeah, and I think it goes back to also what you shared earlier about building that trust with them, so that they can also be the ones who are steering the program.
Right.
Yes, if I could just add to that. I mean, I guess many of us on this call have probably tried to work with governments in different parts of the world, and you think, well, perhaps it's easy to just do this ourselves, actually, because it takes a long time to build trust with the government. You have to be very persistent. You build a relationship with one member of the government team, and then they get transferred somewhere else. And I think it's absolutely marvelous the way you have managed to persistently be utterly determined to relate to the government, and for them to understand that they themselves need to actually be the ones, because you will not be there forever, but they will be. And especially the way that they have encouraged you to sort of be part of the planning team. I mean, that is really, really great. And also what I love about these programs, how, sometimes it's the community that is sort of not actually participating. You're doing things for the community, but in your case, the community themselves are doing it. And so you've got government doing it and community doing it, which means that if you've got an active government and an active community, the NGO or the civil society organization gradually becomes less important once you've really got the thing solid. And it's really exciting to see this process actually happening. It's tremendous. I think these stories are so important. They need to be shared very widely, because there are so many people who start and give up because it is difficult.
Right. Yeah, that was our effort. That's why we have taken selected the people from the community, so that they feel in the project sense of belongingness. And right from the beginnings, we were very transparent. We said, this is our objective, what we are going to do it, what we can do it, what we cannot do it. So right from the beginning, we were very transparent. Initially they said, oh, what sort of NGOs you are here, just you are talking and sharing the knowledge, it's not going to help us. You see the other NGOs, they are giving us food, some are giving scholarship, some are helping with the agriculture. You are just here and talking and talking. But later on, when they see the benefit of right-based approach, if any organization is not going to be there by giving any sort of support by any NGOs is not going to sustain. But after all, it is a government responsibility, and there is a respect. So when you demand and the government do it, so when they are seeing the benefit of this right-based approach, so now they are becoming more demanding.
Fantastic.
Great. Thank you both. If there is maybe one last question, if you have any question that you maybe want to ask Jeet or Winnie, just feel free to unmute your mic and ask them a question, and then we can finish there. I think one last maybe question that I have is, as people are interested in getting into advocacy, and contributing to policies, they may maybe have had many voices out there, maybe many misconceptions. So I don't know, Jeet or Winnie, if you're there, if maybe you have worked with people who have false beliefs about advocacy. Do you know what those false beliefs are? And maybe can you maybe bring a sort of encouragement to maybe share that those beliefs are not true and that you can actually get involved?
Yeah, Brian, if I may just add a little bit onto the conversation. It is true that advocacy work is not easy. One, because it is not like distributing food or even paying school fees that you can see immediate results. But sometimes advocacy work takes a long period of time to even achieve a milestone. But even if you want to, let's say you're working on a policy or you want to see a change on a specific area, but what you need to know is that it's likely not to be easy, but just count the little progress that you make counts. For instance, when you start, you're not able to have conversations with the decision makers, let's say the MPs or even the MCAs, the member of the county assembly representatives. But then you start engaging them, and then they're able to listen to you. You can start having these conversations, and then at some point you reach another level where you can now start proposing, working together with them on bills, and then they're able to table these bills in the parliaments, in their house, in the houses. And then, so it means as much as we can, sometimes we're not able to obtain or achieve a solid outcome that is tangible, but some of these little steps that we make still counts. And so advocacy work is not in vain at all. The little achievements we make count.
I'm reminded of this saying that says the journey of 1,000 miles begins with a single step. And so it's about taking those small steps, and then ultimately you will see the impact. Lastly, Jeet, I think in your presentation, you talked about, having those steps to advocacy. I think we would be interested in maybe having a copy of that, and because I think it's really interesting that you have outlined that if this happens, then this person needs to do A, B, C, and D. And I think that sort of structure is really helpful. I don't know if maybe you have any comments about why having such a structure is really important.
Yeah, because it's very important to make a way to proceed ahead. Unless we have a map, then it is a bit difficult. So, like, there is a 5 steps. We develop the 5 steps. First, the evidence or the problem, and then translate into as a community what you want. And then second, the policy relevance. What is the policy? What is the program? And how you going to justify it? Then third step, then what would be the solution for this problem, and then outline the agenda and what action really you want to see the change. And then just you should be very clear, you should have some kind of solution also, so that when people ask you, you should be able to say, okay, this is the problem and this is the solution we have. And then the strategy now, how to mobilize the community, how to mobilize the stakeholders, how to mobilize the people with psychosocial disabilities, then how to mobilize this media, and how to mobilize the as a organization. So then develop those plan, again co-design with the community, so that everybody is clear who's going to play which roles. And then translate all the evidence and then have a meeting with the authority person and explain them all those things. But this is like of course it is a time consuming step. You need lot of patience, you need to do lot of follow up. But and another things, when you have a very solid database which reflecting the gaps and challenges, then definitely these policy makers are going to listen to you. So that
Right.
is very important. These policy maker people are really, honestly, they also want to bring some good and very effective policies. But the problem is that they don't see any people there who can really advise them very good policy. What is happening here in Uttarakhand, especially, we are doing lot of advocacies, and then we are also doing not very high five type of research, but our learning research, and we are sharing with the DMHP team. And what we did on the occasion of Mental Health Day, because the DMHP also celebrate, we also celebrate. So what we do, we always bring the people with lived experience and the health department team, and then both the people, then they share their problems, challenges, and gaps, and then it's really helped them. It almost took us to 3 years.
Mm.
So these things are very important when it comes to influencing the policies.
Yeah, yeah, I agree. I agree. Well, thank you very much, Jeet. I'm sure we've all learned from what you've shared and also from what Winnie has shared. I believe that our time is unfortunately up, and so I'd like us to end it there. But this recording will be available for you to revisit and to share. And also, I will also come up with a brief write-up on our discussion, and then maybe Jeet, you can point me to the structure just so that I can also write how to achieve that. And then Winnie, also your slides would be really helpful. But with that said, thank you all very much for joining us this evening. We really appreciate you taking time, and we hope that you've had a learning experience and that you will go out and be confident in advocating for mental health. So thank you all very much, and I do hope you have a wonderful and blessed evening. Thank you so much.
Yeah, thank you so much.
Thank you and
It
bye.
was my pleasure to share my all the experience. So thank you.
Thank
you
you
very
all.
much.
Bye.
Thank you so much, everyone. Bye.
All right. Bye bye.
Bye.